Dr. Roger 1913 letter, and distribution of the female patients. So 20% of the cases there is association with a family history of food and neurological problems. And whereas 50% of the patients, they have bilateral problem which is present, and some have unilateral conditions. On other side, in some of them, congenital talus equinovarus can also be found. 50% of the patients have a strong association with other conditions which include the neurological disorders, including the microangiopathy, the arthrogryposis, bone belly syndrome, and Jsmu 13. Other visceral anomalies that are related to cardiovascular and gastrointestinal system can also be found. And regarding the inheritance, in 20% of the cases, vertical talus, there is autosomal dominant found. And genes which are associated HOXE10 and CDMP1, which is related to TGF beta, is also found in certain other conditions, including the brachydactyly and acromesomelic dysplasias. So pathoanatomy changes in the skeletal structure, in the tendons, in the ligaments, and the changes because the bones are plastic, the bones ultimately become deformed and the foot becomes deformed if left untreated beyond 2 years of age. So skeletal anomalies will go step by step. First with the reticular is dorsally, and so it is articulating only the superior aspect of the neck of the talus. And the proximal articular surface is treated, plantar verts and regular talus. Considering the calcaneum is plantar flex, and in some cases it is displayed posterolaterally or laterally, and it is contact with the distal aspect of the fibula. It is so laterally deviated that it becomes in contact with the lateral aspect of the fibula. And the calcaneum cuboid joint is also subluxed or it may be dislocated. So due to the plasticity of the bone, the shape, the changes becomes permanent. The talus which is become flat and medially head, it becomes fixed, and the navicular becomes wedge shape, and the systematic head which is supporting the talus, the superior aspect of the calcaneum, is also becoming hypoplastic if left untreated. There are some abnormalities in the ligaments also. The spring ligament on the medial side which is also attenuated, and the navicular portion of the superficial deltoid is markedly contracted, and it is sustaining the navicular in this dislocated position. Other affected ligaments include the bifurcate ligament, the calcaneus navicular and cuboid, calcaneofibular ligament, and the calcaneus interosseous ligament. These are also become attenuated. The joint capsules, these are also which are positioned in the bone, they also become contracted, especially in the dorsolateral aspect, and the talonavicular joint capsules, they become significantly contracted. Considering the tendons, there is also contractures in the tendons as well. The tibialis anterior tendon, long coextensor, peroneal brevis, and triceps. All of them become contracted. The posterior peroneal tendons becomes anteriorly subluxated over the malleoli. So they are now acting as a dorsiflexors as compared to the plantar flexors. And this is the which is showing the tibialis posterior which is become attenuated, the line of pull of these tendons becomes significantly changed, the extensor digitorum longus becomes hyperplastic and will become more stronger. So vascular supply, it is also important. The dorsalis pedis and anterior tibial arteries are major supplying this major vascularity with the foot, whereas the posterior blood supply also becomes attenuated. If we do significant anterior dissections, if we compromise this blood supply, then the foot is at risk of vascular insufficiency. So if left untreated, this deformity ultimately becomes fixed, and the shape of the bone adjusts to this because the bones are the plasticity of the bone, these are cartilaginous. So it is better to treat below the two. Weight bearing of the congenital vertical talus occurs to the head of the talus, and results in the poor balance and the push-up, and ultimately leading to the painful feet. And we most often encounter the congenital pelvic monovarus. It is a comparison between the two things in the picture. You can see the 4 foot in the congenital pelvis is.
Thank you, doctor. Thank you, doctor. Now I call upon Dr. Parvez Ali to talk about clinical evaluation and differential diagnosis. Assalamualaikum. Today my topic of presentation is clinical evaluation and differential diagnosis of the patient. So this is our surgical complex of the Jpmc. And this is our pediatric orthopedic team and the pediatric orthopedic OR. This is our club clinics. We are doing the club patient as well as vertical Talus and congenital distribution patients for the conservative treatment. So first of all, definition of vertical. Can everybody tell me what is vertical talus? No. It is navicular is displaced dorsally, and the shape, the talus head of talus is located medially and is vertical. So it is non-axillary, and navicular displaced on the dorsally talus head and neck and talus vertically leading to equinus of the foot, and then the practice of the tender leads so it develops of the foot. It is very rare condition, 1 in 10,000 patients. The ratio of male to female is same, and the 50% of bilateral. The term used in Hatchins in 1940. Second sentence is congenital pes valgus deformity, upper bottom reverse club foot, and Talus convex pes valgus. What is by reverse club foot? Any idea from the audience? जाग रहे हैं, सो रहे हैं साथ? क्या क्लब फुट में रॉकर बॉटम फुट डेवलप होता है? यस होता है। कब होता है? ओवर करेक्ट जी, कब होता है?
जब पहले केवस को करेक्ट करते हैं, फिर पहले केवस को करेक्ट करना चाहिए, बाद में एक्वाइंस को करेक्ट करना चाहिए। पहले एक्वाइंस को करेक्ट करते हैं तो उसके बाद केवस ऊपर बॉटम
राइट। ठीक है, आप क्या करते हैं, फोर्सफुली डॉर्सिफिकेशन करते हैं ना, तो टेंडरली स्ट्राइक होता है, उससे जो है जब टेंडरली स्ट्राइक होता है तो आप क्या करते हैं, फोर्सफुली करते हैं। ठीक है, टेंडरली को लेकर के हम को दिखाने के लिए कॉन्वेक्स शेप अगर मिड फुट इसका लोकल not perform at long. या तो मोबाइल भिजवा there is an navicular dislocation, plantigrade talus, and associated with four-foot adductor and dorsal. There is a flexure of the flexor helix is longer and flexor is longer and talus tendency. And head foot is open and there is a valgus as I will show you. The exact activity of the talus is not known. 50% of the genetic problem. Positive family history, there is a chromosomal defect of the chromosomes 13, 15, 13 and 31. And there is some muscular Abnormalities also associated with hyperactivity, arthrogryposis, spina bifida, meningomalocele, and cerebral palsy. Therefore, although the clinical and neurological genetic workers warranted for typically the clinical presentation is four, it appear on the upper bottom. Kind like a full slide like I'm not talking. There's a calloustic formation and there's a calloustic formation. So blood usually they may be ulcer, the arthrogrypoid or neurological problem. On physical examination, you will see the inspection always look, feel, move. On the inspection, you will see the convexity of the plantar surface of the foot and medial seven head. Progress unit seven head development on the lateral side, but in the medial side vertical side, and see the rigidity when you do the movement of the foot. Assessment of pedality, which is very tight, and the lead on the equipment, it is conduct with the permission reflection. And neurological assessment for the spina bifida and meningomalocele. Directly associated with, as I told you, the neck leg, usually the pelvis formation, and there is a callousal formation. Posture of the foot, plantar surface, and the convexity of the foot on the, look at here, there is a convexity on the plantar surface of the foot, and the foot is everted and valgus, everted and valgus. Forefoot is also on the valgus position, heel is also on the equinus and valgus position. And prominence of palatal on the medial side will palpate on the navicular usually displays on medial and dorsal surface. The skin crease abnormally plantar and anterior crease may be different. And there is a lot of callousy when patient is walked by through. See the palpation, it is rigidity, tendons are tight. There is a heel bisector line which is drawn from the calcaneum to the forefoot. Usually line bifurcate from heel calcaneum to the second and third toe. Foot and spine is also mandated for the treatment purposes. Bilateral associated problems in 50% of cases there is an arthrogryposis, as I told you, the arthrogryposis spina bifida associated with the hip dysplastic and the chromosome abnormality. Sometimes patient can do one side in the vertical talus and another side with the float, and sometimes it is with the vertical talus with congenital knee dislocation as well. The differential diagnosis of the talus, fascicular deformity, tarsal collision, and as I told you, clubfoot therapies with the upper bottom development and fascicular valgus deformity of the foot, and neuromuscular problems like cerebral palsy and neuropathic foot and myopathy as well. The radiological assessment, as Dr. Asopra will tell you, you will see the basic lines for the APL lateral view, see the angle of lines, and lateral view is very important for the Mary's angle, and see the navicular on the dorsal surface, and talus is totally vertically. There are 5 to 6 points where you can see on the lateral view. The long axis of the tibia and talus is same. Navicular is displayed dorsally, and the heel in the equinus, valgus, and forefoot is abducted. The congenital vertical talus falls. There is a severe fascicular deformity, has a vertical talus but no equinus. The upper bottom pointed foot has persistent equinus but not implanted in talus. Radiological finding as an angle in deformity and valgus, forefoot and valgus. There is a direct dislocation of the navicular joint, navicular articular surface on the dorsal surface of the talus, blocking it on the front surface in the vertical position, and some relaxation of the Jpmc soft tissue. The conclusion, early and accurate clinical evaluation is very important. The required index of the species and skills, evaluation and the radiograph to confirm the diagnosis. Clinical sign is guide for the urgent matters. Any question? Other question?
So, I will put X-ray examination. We should know some fact about that. At birth, the calcaneum and the tarsal bones and the talus is ossified. So, bile is ossified at the age of 1 month. And naviculum and cuneiform are not ossified till the age of 2 to 3 years. So that is important. Although you presented, you heard that there is a dislocation of the navicular gland or the talus in the vertical talus, but you cannot see naviculum on the X-rays. That's why you use this metatarsal for assessment of the position of the naviculum. And this is a fundamental principle that all foot and X-ray should be taken in the standing view. But in the children, in infant and children, standing is not possible. So that's why you just do simulated. You just use some plates to make foot with the dorsiflexion, and you simulate it. You standing X-ray you will take. Sometimes you need frontal flexion view as well to differentiate between two conditions. So we will see that at the end. So X-ray helps in diagnosis and in differential diagnosis, and sometimes it will help in for the assessment of your treatment. And you are treating the patient, although clinically there is some improvement is there, but maybe the trial you could not find improvement. But anyhow, this X-ray is not substitution of the proper clinical examination. So, few angles. First of all, we should know the normal, and then go for the assessment of the pathological angle. First angle is the tibial-talar angle. You just draw a line from the center of the tibia and center of the talus. This angle is usually around 115 degrees. In infant, it is a bit larger, but as the child starts walking, it will become big. So usually around 100 degrees. This is very important angle. Actually, those people who are treating the foot problems, and very difficult to know whether we should go for the English terminology or not. This is the tibial calcaneal angle. Actually, you draw a line from the center of the tibia and one from the inferior surface of the calcaneal. So this angle is usually around 80 to 90 degrees. 80 degrees on average is 80 degrees. If this angle is increased, it means this the calcaneum is the equinus. And if this angle is decreased, it means the calcaneum is in the calcaneal position. So this is very important. See in this X-ray, if you see that the tibial-calcaneal angle is increased, it means there is some equinus problem with the calcaneum. This again, these are very technical. This is, you draw a line from the center of the talus, the first metatarsal. So you use a straight line, with plus minus 4 degree angle is acceptable. If this angle is become positive, more positive, then it means there is some bias is there, and if it become negative, then it means there is some pes planus is there. Again, in the lateral view, if you see, these are lines from the center of the calcaneum and from the center of the talus. The center of the calcaneal line is passes through the upper part of the cuboid, and the center, this line from the calcaneum is passing from the inferior part of the cuboid. This is the normal. In AP view, again you see the talocalcaneal angle. So this is not usually 40 degree. This is a line from the center of the calcaneum and the talus. So if this angle is increased, it means there is some inversion of the calculator. It means there is some valgus deformity of the foot. And if this angle is increased, it means the valgus deformity of the foot. Again, in the lateral view, we just see the line passing from the center of the talus and the center of the calcaneum. That is also around 40 degrees. Again, if this angle is increased, it means there is some valgus deformity. And if this angle is decreased, it means there is some valgus deformity. So after this basic knowledge, now we'll see what happens in the vertical talus. If you see this calcaneal angle, this angle is increased. It means the calcaneum is in the equinus position. This is the line for the meridian. If you see this separate malclosing of the talus. If you see the talus angle, that is also marked in blue. So this is showing the vertical talus. In ATU, if you see this is a line from the center of the calcaneum and center of the talus. This angle is marked in blue. It means the foot is in the valgus position. Again, in the loop, see this line. Although this line from the calcaneum will pass here to the superior part of the cuboid, but this line is going inferiorly. It means there is a equinus deformity of the calcaneum. So now this is the vertical talus again. See, this markedly increase very angle is in the negative. Calcaneal angle is increased. So this is the vertical talus. So last but not least, again this is the say you can find the vertical talus. Marriage angle is markedly increased. It means this is a vertical talus. But this is a passive flexion X-ray. This is normal X-ray we are doing. But in doubt, we should do plantar X-ray. And in plantar X-ray, if you see the line, this marriage angles are now zero. It means this is not vertical talus. This is a case of oblique talus. In vertical talus, even in the after plantar flexion, this angle will not vertical. So. I just want to add one word because radiologically I was thinking this only the X-ray, but just in last lecture something will come in my mind. So vertical talus is basically sometimes is associated with arthroptosis, and you people must know this arthroptosis means the involvement of the vertebral joint. So if there is a vertical talus, you should must go for the screening of the hip joint as well. Usually in the children this below 6 months of age, X-ray is not handled. You should go for the ultrasound of hip. This is also part of the radiology. Thank you.
Today's my talk is Hello. Today's my talk is Dope's reverse pulsating technique is the E-open technique for CPT. Already discussed this condition is multiple names, whatever you want to call proper bottom, partial sleepers, or any vertical talus as you like. Goal is to restore and maintain the normal relationship of the talus, clavicle, and calcaneum in order to promote normal already discussed slides. Take equivalence is present in both conditions, but less obvious in vertical talus due to flexion contraction of the anterior and dorsal structure. Otherwise, differentiate already Dr. Jsmu discussed forefoot and plantar flexion reduction and vertical talus, forefoot dorsal flexion, and the abduction, hindfoot varus, and equus, while the vertical talus is valgus and equus. We already discussed, but I want to only summarize a talus. A talus head and neck flattened, deviated medially and plantar vertebra. See कि आपको talus बिल्कुल आपको नीचे जो उसके एल्किनियम आपको प्लांटर फ्लेक्स मिलेगा और एक्सरे रोटेट मिलेगा, नोविकुलर आपको बिल्कुल उसके एक के ऊपर आपको मिलेगा, क्यूपाइडियली डिफॉर्म लैटरली डिविएटेड। Treatment is tailored according to the severity and age and presentation. In general, surgical intervention is required until the age of at least 12 months of age. Don't describe the reverse falsity method using serial manipulation and casting of the deformed along with minimal invasive surgery to correct CVT. So, reverse falsity technique aim is to estrange the contracted dorsolateral soft tissue structures and to reposition the deformity as much as possible. Methodology is similar to the falsity methods of treatment of the clavicula, but in reverse direction. All components of the deformity are corrected simply with the description of the hindfoot equivalence, like clavicula, differentiate the crucial step is to locate the head of the tail, usually lying at the plantar and medial aspect of the अगर आप ये देखेंगे तो आपको ये प्लांटर प्लेट और मीडियल साइड पे आपको हेड मिलेगा। तो फर्स्ट स्टेप पे आप लोकेट, क्योंकि अगर आपने इसको लोकेट नहीं करके को प्रेस करेंगे तो कभी भी आपकी डिफॉर्मिटी करेक्ट नहीं होगी। तो फर्स्ट स्टेप क्रूशियल ये है कि आप उसको लोकेट करें। सेकंड क्या है, मैनिपुलेट करना है, एटलीस्ट 2 मिनट्स आपको मैनिपुलेट करना है। मैनिपुलेशन का help on one side is placed on the head of the tailor and posterior medial press while the head gently stretch the foot and plant and this effectively assists in opening the talonavicular joint and facilitate retraction. ये डायग्राम में आप इसमें भी आप देखिए कि वो एक तरफ से वर्टिकल टेलस को प्रेस कर रहा है और फुट को जो है आपको डॉर्सिफ्लेक्स कर रहा है ग्रेजुअली, और उसके बाद उसकी डेट को रिडक्ट करें। ये आप देखेंगे डूम्स की वीडियो है, आप इसमें देखिए आपको उसमें बता रहा है कि टीम जो है वाइलस में पड़ी 4 फुट आप देखिए तो आपको एब्डक्शन मिलेगा, और जो मेथड भी बता है मेडिटेशन किस तरह करें। आप इसे थंब उससे रखा है आपका उसमें इसी तरह वो मेडिटेशन ये 2 मिनट के लिए मेथड बता रहे हैं आपको। अब इसमें पोस्टियर देखेंगे कि अगर तो पूरी खुद होके करेक्ट हो रही है। अब ये मेथड बता रहा है अगर कैलकुलेटर में आप प्रेस कर रहे हो तो क्या प्रॉब्लम होगा। अब आप ऐसी की वैसी ही दे रहे हैं, तो उसे यही बताया है कि आप कैलकुलेटर को प्रेस नहीं कर रहे। Hold and maintain the knee in 90-degree flexion, foot in plantar flexion, trapezoid flexion, the casting, long leg slide in 2 sections. पहले आपको below नहीं करना है, इधर above नहीं चलेंगे। Avoid constant pressure at a single point Here, take carefully bold the arch vapula and head of the talus was Stars to be changed weekly in order to maintain its effective rates. Usually 4 to 6 spots usually enough to achieve reduction of the calorific cost. With each weekly cost is put brought into both equals and to bearers 4 foot in maximum plant reflection and 1 should to ensure any stretching of the contracted dark to lesser encapsulated skin. And last put select the position of pillar जैसे बड़े सारे कारण pillar foot में हो सकता है तो vertical talus पे pillar foot होता है आखिरी कास्ट में उसकी लुक बिल्कुल pillar foot की तरह है no attempt is made to correct economic deformity during the position of cast जब आपकी 4 to 6 कास्ट हो जाए फिर आपको evaluate करना है उसके आपको lateral leg करना है plantar flexion यूजुअली हमें क्या दिख रहा होता है टाउबा एंगल एक ही एंगल है जो आप देख रहे हैं तब आप ये क्या करते हैं कि ये आप देखेंगे एक लाइन यहाँ पर वर्टिकल टेल के साथ निकालिए एक पास पे कटा अगर ये आपकी 30 डिग्री से कम है तो दिस रिड्यूस है अगर नहीं है तो भी अभी तक करेक्ट नहीं हुआ तो आपको अदर मेथड सोचने पड़ेंगे कि आप क्या करें joint is reduced टाउबा आपकी less than 30 डिग्री तो आपको क्या करना है वायर पास करनी है रेट्रोग्रेड फ्रॉम लॉन्गिट्यूडनल टू टेलस आपको एक वायर पास करनी है और तो आपको वायर छोड़ने के बाद भी आप निकाल सकते हो अगर और के बाद आपको करना है वायर पास करनी है उसके बाद वही आपको रिगार्ड भी करिए रिगार्ड के लिए जरूरी है कि पहले आपको वायर से पहले फिक्स करें बाद में रिगार्ड भी करिए क्योंकि ये लेबर का प्रोसीजर से लिए वही मेथड चाहिए आइडियल है अब है वो 50 डिग्री है तो फिर आपको क्या करना है ट्राई जॉयस्टिक टेक्निक तो आपने एक वायर पास कर दी और उसके साथ जॉयस्टिक करके आपको यूज करना ठीक है अगर आपकी वो इस मेथड से भी नहीं आ रही है जॉयस्टिक तो फिर आपको क्या करना है ट्राई सीधी ओपन टेक्निक आप क्या करना है सिंपल डिसीजन देना है आपको जॉइंट के ऊपर और उसको ओपन करके कैप्सूल का भी आपको डार्सल कर दिए और या लीवर नीचे रख के एलिवेट करके आपको केवल पास रियली इंसाइडर टीम टेस्ट भी ऑब्स्टिकल तो काफी दफा क्या होता है कि पैराडाइज की ब्रेन स्टेटस और टेबल इन्फेक्शन जैसी जड़ी पड़ती है अगर रिडक्शन की प्रॉब्लम अप्लाई long leg off with foot in the neutral and ankle wide in the dorsal flexor शुरू में उसके बाद आप एक 2 हफ्ते के लिए करना है 2 हफ्ते के बाद फिर दोबारा क्रॉस चेंज कर लिए 10 to 15 डिग्री फ्लेक्चर में और 5th वीक आपको क्या करना है के वायर को रिमूव करना है के वायर को रिमूव करके आपको शूज दे दिए हमारे सिस्टम में रिवर्स डीबी शूज कहते हैं टिल वॉकिंग है शूज के भी होते इसमें क्या होता है आपको न्यूट्रल रखने होते हैं जैसे आप एक्सरे रोटेट करते हैं इसमें आपको न्यूट्रल रखना है बाकी वही है शूज पहनने का भी तरीका वही है हर चीज वही है कोई डिफरेंशियल नहीं एक में जब सारी चीजें हो जाए तो एक और भी चीज है कि पेरेंट्स को हमें सिखाना है स्ट्रेचिंग एक्सरसाइज के ताकि फुट हमारा सफल रहे और रिकरेंस लाओ तो आपको उनको बताना है कि फुट की एक्सरसाइज भी करते रहना है literature क्या कहना है कि unlike killer foot casting CVD casting has not been used until there is a method of definitive correction definitive correction के लिए कभी नहीं यूज होता even case corrected later by surgery this very special case approach of pre-stress the soft tissue सिर्फ ये soft tissue को स्ट्रेच करने के लिए therefore decrease the complexity of सर्जिकल प्रोसीजर ताकि आगे आपको जो भी प्रोसीजर है regardless of the age of the patient I don't third patient or primary or revision always Disorders should be recognized at birth and treatment before the age of 2 years. Younger the patient typically more flexible with deformity gets started talking to their child. More rigorous procedure must be prescribed if late. It should be explained to the parents these steps of the management are follow. The data will take longer time. It also takes very operative procedure. But this part of the risk of treatment is not followed carefully. Is not more you follow the system, better you will get.
Thank you, Professor. Next, welcome Dr. Nishu for a session of surgical management in United States. मेरा नाम आपको अटेंशन चाहिए